Ladies and gentlemen, welcome. Thank you very much for coming. My name is Marc Grossman. I have the good fortune to be the chairman of the board of the Senior Living Foundation, who brought you all here together today. I must say I've got the easiest job of all and also going to be the shortest, which is to welcome you and also to say some thank yous. So first, welcome. We have believed over the years that part of our mission statement, which is taking care of our own, includes organizing every other year this seminar, Planning for Change. Because change is coming, and it comes to everybody, and that taking care of our own means that we ought to be able to convey as much information and as much consultation and as much effort to let you know kind of what's out there so that you can make some planning and do some thinking and get ready for that change. We've been doing this now for many years. I see a number of people who have been here now, certainly on a number of occasions. But each year, we try to focus in on those topics we think will be most interesting to people. And every year I leave here having learned something very important, and I know that you will do so today. So thank you very much for coming, and welcome. Second, I wanted to just say some thank yous. And the first thank you is everybody in this room knows that these kinds of events here at big hotels with all of this invitations, they don't happen by accident. And so I hope you would just join me in thanking all of the people from the Senior Living Foundation who've worked so hard over these last few months to make this happen. So thank you very much. Second, although the vast majority of the donors to the Senior Living Foundation are year after year after year people who give between $25 and $75, $25 and $100. There are some donors who do more than that. And I just wanted to say how much we appreciate that. And I see, first of all, Paul Deming, I saw come in. Thank you very much, Paul. Dacor is a great supporter of the Senior Living Foundation, and we thank you. And perhaps you'd join me in thanking Dacor for that support. And secondly, we have sort of double thanks today, both to Aetna and to Express Scripts, who both work very closely with the Senior Living Foundation. Both make a donation, and as you know, are sponsors of today's events. And again, if you join me in thanking them. I thank also Jim Gadsden, who is here, Ambassador Gadsden, who is a member of the Board of Directors of the Senior Living Foundation. Jim, we thank you very much. And I think Sharon Wilkinson will also join us, and I'll look forward to seeing her. And finally, to the people who are speaking. You've seen the outline, you've seen the schedule for today. Every single one of the people who've come here today have come here on their own. They come voluntarily. They come to be a part of this event. And we really appreciate it, and we thank them very much. I know you thank them individually as they go along, but if you allow, come and thank all the speakers today all at once, and I appreciate that too. So, welcome. Thank you. And my next job is to turn over to Jim Eaton, who again has come a long way, as he does every year, to kind of be the MC of our program, Jim. And we appreciate your support, and we appreciate your commitment to taking care of our own and also to this question of planning for change. So thank you all, and let's have a great day.
Thank you. Glad to see you. I have to be careful now. I've been coming so many years that I'm now 81 years old, and I have to be very careful when I step up on high places. And I know the physicians appreciate my saying that. You all do too. It's a pleasure to be back. It's a great pleasure. It started for me in a meeting with Paula and Ambassador John Shoemate close to 30 years ago, the ideas of the foundation and getting it kicked off so that people who are carrying it forward, including Paula, have made it very successful. And I haven't missed a meeting. I haven't been very far out of touch ever with this organization, and it's remarkable. And you need to take all the advantage you can of what they have to offer. Feel free to adjust your chairs when when speakers are using the slides here, there's no gourmet meal coming while we're having our presentation, so it doesn't matter if you move them into the aisles a little bit and get a good view of that. And my most important duty, the men's restroom is directly across from the entrance to this building, and the ladies' restroom is just down the hall to the right a little bit on the left. I always get a chance to say just a few words about and not only how successful and not only how nice the investment account looks right now for this foundation. There's so much more to do. I've had the opportunity to be involved in initiating 2 other foundations about the same age as this one, doing very, very well. And I've just finished 10 years as chairman of the Hospital Foundation in Jackson Hole, Wyoming. And we're just about to start a new nursing home, living center, and memory care unit for a total cost of $42 million. And the foundation has $42 million of cash in the bank, and that'll start next spring. And that's the goal. The goal is to grow and to grow and to get additional sponsors like the 2 that have just been introduced here today, and the programs will grow with that. But it's a remarkable job, and pleased to be a part of it. Probably the last thing I should tell you is I live in an assisted living facility, and so they don't know quite what to do with me. Having a long background in it, I'm the only independent resident living there. But it's been a treat for me to be there and to see the advantages of those facilities and to see the coaching, which we'll hear about today, the marvelous work of the social workers, which we'll hear about today, and I've known and you know about the nurses, but this facility has got more of a very nice residential feel, and I'm enjoying it there, and I'll probably stay there. Because if I left, I would need it immediately. I know that's what would happen. So it's been an enjoyable year for that reason. I am happy to introduce Dr. Rosenfarb to speak with us next, and those of you who have been here before know him and know that he's one of the faithful of your group and medical director for the Bureau of Medical Services, and looking forward to learning some new things from you this year like I did 2 years ago. Good to see you.
That is quite a step, actually. So thank you, Jim, and thank you, Ambassador Grossman. It's always an honor and privilege to come and speak here. I get a regular invitation from Paula. It's not really an invitation, it's more of a command order. But Paula's amazing, and I just want a special shout out to her. I don't know of anyone, I've been doing geriatrics a long time, I don't know of anyone who's got a greater commitment not only to the Senior Living Foundation, but to seniors in general. So thank you, Paula. So like I said, I really enjoy doing this. My day job is currently the medical director for the Bureau of Medical Services. For the State Department of Veterans out there who know Med, it's been an interesting year for Med. We've been in the news more than we want to be. There's been a lot of this past year doing congressional briefings and testimony about incidents in Cuba and China. And so this is actually wonderful to be here, rather than talking to OMB or a congressperson. So thank you again. When Paula asked me to do this, she said, what do you want to speak about? And I said, well, how about mental health issues? Because I always thought that was under-discussed, frankly, by geriatricians, by doctors, and often ignored by seniors themselves. So I said that, and then the next thing I know, this brochure shows up from that says a roadmap to better mental health. And I have to thank Twinisha for that. That was her concept, and when I saw it, I thought, that's perfect. because, to better health and mental health and physical health really is a journey. And you have to kind of follow a roadmap, and there's no Google Apps map that take you to it. So, do I have a slide? So again, hopefully, we'll talk about some general stuff, some specific stuff, and kind of the journey to good health. So the road to well-being begins with good genes, and I think I spoke about this 2 years ago or 4 years ago. If you're not born with good genes, you're behind the 8 ball. And one thing I've always said when I was lecturing in geriatrics back in my previous life at the University of Maryland was that it's much easier for good genes to overcome bad habits than it is for good habits to overcome bad genes. And that remains true. But good habits do make a difference, and so good habits are important. And I don't have to iterate what the good habits are. I think everyone here lived long enough to know what the good habits are. But good genes and good habits are the start, and that'll help you get good physical health. But more importantly, it also, I think, will help you get good mental health as well. And so we can start on the road to well-being. Let's talk about some general things about the road to good mental health. So as anyone knows, the longer you live, things happen. And how we deal with those things really affects how well we age and how well we do. So what are the things that happen? Probably happen to many people in this room. You leave the workforce, and that's a big stressor. Doctors have put out lists of what are the major stressors people have, and changing jobs is certainly one of the biggest stressors. Changing your living situation. Jim talked about being in assisted living. And that's a really good choice for many people. But any change, whether you move from your own house to your relative's house to assisted living, that's a big stress. And that happens to people as they get older almost inevitably. The physical problems you deal with, you fall down, you break a hip, that's an incredible stress. And I always use the analogy, kind of the Humpty Dumpty analogy when I was teaching and lecturing, that Humpty Dumpty, once he falls off the wall, to get it back on the wall becomes very, very difficult. And it's much, much harder for people over the age of, and I always thought it was around 68 was a point where it becomes really hard to sort of get back up on that wall. Loss and grief. It's as you get old, you may lose friends, spouses, and that is a tough thing to deal with. And then caregiving. You have to end up giving care not just to yourself, but to a spouse, to maybe friends and family. And that's an incredible stressful thing as well. In general, I think one way to look at aging, unfortunately, is aging is an accumulation of loss. The things that, you pass the peak of your life perhaps, and you start losing things over time. Obviously, the loss of a spouse is one of the biggest stresses I mentioned. And, it's the rare couple that dies on the same day, but it's amazing how many married couples die within weeks to months of each other. That's been studied. No one knows why, but I think certainly the mental health aspect and the support plays a role. We all lose friends. When I was seeing patients in my geriatric practice, I always said to them, people don't worry so much about losing their own life, it's losing their friends. And that's really tough on people. Loss of savings. Hopefully everyone here has made some good decisions, have lots of money in the bank, but inevitably that gets spent down, so kind of your savings gets depleted as the older you get. Your physical strength. One of the big medical issues people have is frailty. That as much as you may try, your muscle mass goes down, you become more frail as you get older, you lose some of your strength. And your physical health as well. And also, I just wrote forever, but it's something that, they joke about people middle age, you kind of lose your sense of immortality. You know that, one day the end is coming. And obviously, the older you get, you kind of realize the end is coming sooner and sooner than you might have wanted it to. But that sense of loss, that loss of immortality really does play a role for people. So of course, the important thing is how you cope with those issues. And we're going to hear from coaches later. I think that's going to be a good segue from this one, this talk. So how do you cope with some of these things that happen to you in life? Well, physical, healthy behaviors are probably the major thing. People advocate exercise, healthy eating, healthy living. That'll help you cope with some of the things that happen to you. Social networking is incredibly important. All the studies show that people who have friends, who socialize, they have better outcomes in life. And it becomes more important as you get older because it's much more likely that you could become isolated. Sorry, there's a glare up here, it's hard to see. With that social networking, it's not just necessarily being with people, but it's developing those strong, positive, personal interrelationships, the good friend, the support person someone who will help you go through the journey. And then what I wrote up here was reasonable accommodations. I don't know if there's anyone from the HR world, the human resources world. Reasonable accommodations is a big term there. But when I put it here, I mean, make accommodations with yourself. You kind of manage your expectations. You know, example is, if you're someone who likes to entertain, and you might get frustrated because you can't put on the 5-course dinner that you used to be able to when you were younger. Make accommodations, make expectations a bit lower. Do something that's reasonable for you, that'll give you satisfaction and not give you disappointment. And then for some people, not everyone, spiritual religious engagement is certainly a way of coping with change. So even though you have those general ways as coping strategies, there are dangers ahead. And one of the dangers is actual mental illness, mental health problems. And fortunately, most people don't have to navigate that. Most people can avoid that danger, but sometimes it is something you have to navigate. Sometimes it's something either you or your family member has to deal with. So I want to talk some more specifics about some of the real mental health roadblocks, some of the diagnoses that people have as they get older. These are some similar things when you're younger as well, but I'll emphasize some of the aspects that are unique in the elderly population. So generally, I think we can separate out mental health issues to mood disorders and cognitive disorders. And these are the ones, I don't know if you can see from the back of the room. So mood disorders generally are anxiety, what's called dysthymia, which some people call minor depression. It's in kind of not full-fledged major depression and depression. Cognitive disorders, typically there's 2 types, delirium and dementia, and I'll talk more about each of these. And cognitive disorders tend to be sort of confusional states. People know what dementia is. So again, going back to the roadmap analogy, the key thing to successful aging is to avoid the D states, avoid depression, avoid dysthymia, avoid dread or anxiety, avoid delirium. And if you can avoid those states, you can actually have a pretty successful and happy, last couple decades of your life. So again, let's talk about each one a little bit. Anxiety. Anxiety is incredibly common in the older population. For doctors and people who work with older people regularly, you often see manifestations of that. People may come to the office, they're anxious about not getting there on time, anxious about, what they're going to hear about. And that's kind of not unusual, and some of it has to do with sensory changes, that people don't sense things quite as well as they did when they were younger, and actually natural sort of anxiety about what you're going to hear from a doctor. But I'm talking more about sort of a more generalized anxiety picture, where even the simple things in life can cause significant anxiety in people. And that anxiety can be debilitating, frankly. And it's constant worry. Imagine being constantly anxious, constantly worried, and how debilitating that can be to successful living. Anxiety doesn't often exist alone. Again, the kind of generalized significant anxiety, often you see in combination with dementia, sometimes early dementia, and depression. It often is something that's like a personality trait as well, that people who tend to have generalized anxiety in older years tend to have been anxious people when they were growing up and may have an anxiety personality disorder. Unfortunately, anxiety has ramifications. It increases the chance of physical disability, partly because people who are anxious tend not to do any kind of physical activity. They're so nervous and afraid that they stay home, they become more frail, and that leads to things like falls, etc. So it ends up resulting in more physical disability, not just that anxious feeling we all want to try and avoid. But fortunately, there are ways to treat anxiety. So medication is really shouldn't be the first choice for treatment. Cognitive behavioral therapy, other psychotherapies, counseling does work, and work pretty well if sustained and with a good qualified counselor. A lot of people ask, well, why not a tranquilizer? So when I was kind of growing up in the medical world and starting to see patients, and the classic thing was someone 65 and above coming in and they were taking their Librium back then, or I think Miltown was another one. Valium came to the fore, and almost everyone had Librium, or one of those medications. And we thought, like, what's wrong with that? It makes people feel better. But unfortunately, those medications have incredible side effects and have resulted in generally bad outcomes These days, other than Librium and Valium, there are newer medications that, when used selectively and used, under close observation supervision, can be effective. Names now are Xanax is a big one out there right now, but they do have significant risks of problems. If they're going to be used, they need to be used at really low doses and under close supervision. Unfortunately, one of the problems is they interact with a lot of other medications, and they also interact a lot with alcohol. So it's a disaster waiting to happen in many people. You may take a Xanax, you may feel like, okay, I can get through the day a little better, but again, it's a much higher risk of falls in people who are on minor tranquilizers. They also associate with other things. They actually increase memory loss when used on a regular basis. They can cause problems with urinary retention, and I mentioned falls already. So let me talk about depression. Again, depression is a real challenge as a physician to identify. It's a real challenge because many people are in denial about being depressed, and they don't come into the office say, hey doc, I'm depressed. And they don't tell their family member, I'm depressed. So it's a very under-recognized mental illness in the elderly population. Part of the problem is that many of the symptoms of depression overlap with other physical issues, and people focus on that. Like, that you may feel like you don't want to go out and do anything, and rather than kind of attribute that maybe to depression, you attribute it to your arthritis, and that's why you're not doing stuff. And doctors also have a bias. There's a bit of ageism with doctors as well. They hear symptoms and they do try to minimize them or attribute them to something else, because it's much easier to treat arthritis, to treat physical ailments, than it is to really do the right thing and treat mental health, depression in the elderly. So how does depression occur in the elderly? Often, again, it results from someone. It doesn't often start de novo. It can, but often it's someone who comes from a middle age and younger years. They were depressed. Maybe they weren't fully treated adequately, and they may have continued depression as an older person, or they have a reactivation of depression. What are the triggers? Certainly tragic incidents. I mentioned earlier, loss, tragedy. That can certainly trigger a reactivation or worsening of an existing depression. Health issues. Obviously people will get very depressed about their current health state, and physical problems that keep you from doing those healthy behaviors, like exercising, like eating better, like going out, will help make depression worse. Alcohol, again, will make depression worse. Medications, some medications that doctors give for things even like hypertension, high blood pressure, can have side effects and make depression worse as well. Then inactivity, like I said, it's a vicious cycle. You feel depressed, you don't go out, you get more depressed, and it just gets worse and worse in the cycle. Like I said, depression is really under-recognized in the elderly population. I think there's probably, fortunately now an increasing awareness of it, and hopefully there'll be a greater effort to diagnose depression. Unfortunately, it's not a disease that you can do a blood test for, an x-ray for, determine who's depressed. In some ways, the best diagnostic screen for depression is a simple 2-question thing that a doctor can do literally in 30 seconds. And it's questions, it's a validated questionnaire. Over the last 2 weeks, have you lost interest in doing common things? Over the last 2 weeks, have you not gone out of the house? A couple of simple questions. And if you answer yes to those, it doesn't mean that you're depressed, but it means that the doctor should pay more attention, do more testing, more evaluation, and kind of delve into your mental health history. Because again, depression is eminently treatable. It's important for you to know the signs of depression, know the symptoms. So helplessness is a classic one. Feeling that there's really nothing I can do to make things better. That I'm helpless, I'm in my house, I can't pull out of this. And that's a real cardinal. When they start teaching depression in medical students, they talk about the helpless, hopeless syndrome. You're feeling helpless, you feel there's no hope. And that really is always a cardinal sign of someone having problems with depression. Perseveration on thoughts of death. I'm not going to specifically talk about suicide, but I think it's a lot in the media that the group with the highest rate of suicide is the group over age 85. I mean, suicide is probably unrecognized as well. I think, an older person dies and they may not look into it, but it may have been, someone taking their own life, because that is that constant thought of death. Decreased energy, people who depress often are angry. That's their way of sort of dealing with their emotions. They show anger, and so their family, their friends, their doctors may push them back on them because they don't want to deal with the anger, but really it's a symptom of depression. I mentioned the loss of interest in hobbies and activities. That's a real big one. So if one of your friends, one of your family, they suddenly stop going out, they suddenly say, I'm not going to go, to the play, they even had tickets for it, that's something you need to pay attention to. And trouble sleeping, certainly both ways. Sometimes people sleep too much, and that's like the classic thing, they're sleeping all the time, they'll be depressed. But more often it's the other way. It's insomnia, it's inability to sleep, and again, that's a major symptom of depression, as is weight changes, and the weight can go either way. Some people gain a lot of weight, some people don't stop eating and lose a lot of weight. So I don't have a slide for it, but like I said, it is eminently treatable. Their medications work well in depression, but so does therapy. Again, cognitive behavioral therapy with a good qualified counselor and really does help. Socialization helps, but if that doesn't work, medications under close supervision of a doctor can help. Some of the older medications that were out there to treat depression, Elavil was like one of the ones that I first learned about, had lots and lots of side effects. Again, increased falls, other problems, urinary retention. That class is pretty much not used anymore, except in isolated cases. Once Prozac was discovered, and Prozac became the major medication. It's in a class called SSRI, selective serotonin reuptake inhibitors. There's newer medications besides Prozac out there, and they're not miracle drugs, and they do also have side effects, especially in the older population. They can cause a really low salt level in the blood, hyponatremia, which can lead to lots of physical problems. And also, these SSRIs have problems sometimes with increasing bone loss and more hip fracture or more fractures in older people. So again, it's not for everyone, it's not a miracle drug, but given selectively, given under doctor's care, it can turn someone around pretty easily. I mentioned dysthymia. It's kind of a catch-all term for, some people don't use it, but minor depression, kind of not a full-fledged depression. The symptoms are similar to regular depression. It does tend to be less severe. It's more kind of a feeling of blue state, I feel blue, that kind of thing. But it can progress. Doctors usually don't make the diagnosis unless it persists for 2 years, but it's something to be aware of and be careful about. So let me talk now about cognitive disorders. And again, as I mentioned earlier, cognitive disorders tend to be these confusion states. It affects your memory, affects other aspects of your ability to think and reason and process information. There are two major types of cognitive issues. Delirium is something that probably is less of an issue for people in the room, or hopefully never an issue for people in the room. Delirium is something that doctors deal with in the hospitals quite a bit. It's often happens when someone is taken out of their usual environment and put somewhere acutely, and kind of changes their surroundings, changes the environment, and kind of often changes their sleep-wake cycle. So in medicine, you always tell medical students to watch out for something called sundowning. Sundowning is a situation where someone is hospitalized, older person, they're not in the usual environment, the lights get left on in the hospital often, they lose track of time, and at sundown, typically when they would go to sleep, they're not really allowed to sleep in some ways, and they get acutely confused at that time of night. But delirium is something that can be avoided. It's totally reversible. For folks in the community, it might happen when a sudden change in your living environment, that you break a hip or you fall down and you get moved to some other facility, and this is a new area, you're not used to the surroundings. Maybe you have to go see your doctor, you get in your car and you drive, and it's a whole different path, and you become confused, don't know where to go, how to get there, and that kind of builds on itself, because just that frustration of make sure he looks at you. And I tell people, younger doctors going out there, look at the patient, talk to the patient. You can look at the record later.
A very low-tech way of managing it is a card. Just write it all down and carry it in your bag.
Agreed, absolutely. Okay, yes.
I guess I have a question related to the fact that it seems to me there's a difficulty in coordinating. If we're elderly or over 65, then you may have Medicare, and Medicare Part B is not generous when it comes to treating mental health, shall we say, and then getting the coordination of benefits. But I also want to raise with you the prospect of coding, as in you get certain treatment or certain reimbursement depending on how your doctor's office or the hospital codes it. And we have no way of knowing what the coding is. So you can't say, I'm sorry, this is the wrong code for my issue, because there's no public access to the codes. So if you could just comment on my frustrations.
I understand the frustration. I share it. Frankly, is at the other end of the consumer doctor spectrum here. One reason I left practice 20-odd years ago and joined the Foreign Service and became a Foreign Service doctor was, I hated that part of medicine. I hated the coding part. I've been protected these past 20 years. We have a unique system. We don't have to deal with that. Maybe Paula can talk more about coding and I actually frankly don't know what shows up in a patient portal. Like all the electronic health records out there, it gives you the chance to see your records, which is I think a great advance. See most of it, whether it includes the code, but I think it probably includes the written diagnosis, which matches up to a code these days.
I can comment on that. Actually, Google is a wonderful invention. So it really, if you look up if you go to Google and look up ICD-10,
Yep.
it'll give you all the codes. And so you can actually go and look at your bill and put in that code. And I know it's not fair and you shouldn't have to do the work. That should be the doctor's office to do the right work. But in a perfect world, that would be. But there are other options. There aren't great options, I admit that. And you're right, Medicare has very, how do I put this, because this is being recorded. They have a certain amount of benefits for mental health, but your health plan can very often pick up that other, and your health plan tends to be much more generous with mental health benefits. All of the health plans in the federal program.
I guess what I meant, Paula, was that depending on how the doctor codes it, then it's not that you can't somehow find the code after it's done, but if the doctor codes it a certain way, and it codes it depression instead of dementia, and there's no cover for it, or vice versa, that coding, you're far less empowered to get that changed. And depending on your mental or physical health, you're a lot less able to, just smart and physically strong enough to deal with those constraints. So I just mentioned that as a source of frustration.
There's no substitute
But
for
not depression. It's
no substitute for an empowered consumer. And an empowered consumer, especially in older folks, means you have an advocate, an ombudsperson, a family member who helps you. Wait, I think we're out of time. Thank you all very much. Again, it was an honor being here.
I apologize for jumping in here, and I'm going to declare this a matter of regular memory loss and nothing else. But I owe Dr. Rosenfarb an apology, which is that I had thanked him as a speaker today, and I neglected to mention the important role he plays on the Senior Living Foundation board as the department's liaison. So, Doctor, I apologize for that, but I thank you very much for your commitment to the Senior Living Foundation.